I got one last challenge for everybody here. Thinking about refractory, how do we treat, how do we choose, how do we sequence? I'll highlight that I think at this meeting there's been, similar to that wave of change that we saw in the frontline setting, going from single agent to dual agents, and now it's seeming to now happen kind of in the refractory phase. So we're seeing updated data of cabozantinib plus belzutifan. Has both an upfront and a refractory cohort. We're seeing a presentation in a refractory patient population of lenvatinib and belzutifan. And then we kind of know on the horizon that there's a randomized phase 3 out there. So would love to hear your perspective on just how you all think about sequencing at our current standard practice, and then what your take is on dose and novel combinations, I'll say, I guess, in the refractory setting. So maybe Brad, I'll let you start.
Yeah, I mean, I think the refractory setting certainly changed quite a bit, and there's no right answer. If you look at NCCN guidelines, like in a patient with prior IO therapy, there's no preferred regimen, right? I think there's some things that I think right now are probably wrong to consider, and I think we have 2 randomized trials that show that in patients who progress on immunotherapy, VEGF blockade is not going to rescue an immunotherapy failure, right? So we have Contact 3 looking at cabozantinib with atezolizumab versus cabozantinib, Tenebo 2 looking at tivozanib nivolumab versus tivozanib. Neither trial showed any benefit to giving IO with the TKI, but there's some differences overall, and I think in the cabo-atezo trial, Contact 3, they optimized dose, so 60 milligrams of cabo both arms. Tenebo 2, given some concerns by the regulatory authorities, they used a lower dose in the combination arm. So you look at Contact 3, no difference in clinical outcomes, but actually worse toxicities with addition of atezolizumab. And if you compare that to Tenebo 2, there's actually no difference in toxicities, but there's actually numerically worse outcomes. And we actually did a nice exposure response analysis in a poster, which showed that, yeah, the dose of 1.34 is the right dose for tivozanib, and that certainly correlates with the best response, and actually there's no increased hypertension with a lower dose. So I think those 2 trials to me say, we really need to prioritize TKI dosing, right, and giving the optimal dose. And so giving the dose that's in the study, be it 60, 1.34, if you use Lenev, 18. And I think the exciting data we see from the belzutifan combinations is that belzutifan's a nice partner. So you can partner with TKIs and give the full dose. So we see some really nice safety data overall. That's an option. So I think I look forward to those trials going forward.
I'm probably in the minority. I'm probably a little bit more of a skeptic when it comes to combination therapies in the refractory setting. And part of that is just sort of think about what the goals are. I think with upfront immunotherapy, again, the numbers might be small, but the hope is to get something really long-term, is to give even that chance of cure. I think when we're talking about targeted therapies in a refractory setting, that's realistically probably not the goal at that point. It's to help people live longer and feel better. And that really has to sort of be taken into account with these combinations. And so I think that makes the bar kind of different with 2 targeted therapies, HIF2 blockade plus a TKI. I think response will be better. I imagine PFS will be better. These things will be true, but are you actually helping people to live longer and feel better? And if the answer is no, then I think we have to pause a little bit and say, is that really the right thing to do just because we're getting these upfront response rates? And of course, there's exceptions to that, people who have rapidly progressive disease where response really matters. But for the majority of patients, I think that's the sort of calculus I have to have in my mind.
Yeah, I think there's just a tremendous amount of nuance to caring for patients with metastatic kidney cancer, because every patient that's coming in, you're trying to evaluate what is their pace of disease, what are their sites of disease. And I think one of the things that we don't often talk about as medical oncologists, but many of us are doing, is we do a lot of stereotactic radiation. We do a lot of ablation. We refer to great surgeons at times for oligometastatic disease. And we do a lot of, I would say, kind of touch-up, cleanup work, and you're not necessarily curing most patients with these efforts, but you're certainly potentially resetting biologic clock. You're preventing potentially dangerous sites of having bad outcomes like fracture or potential spinal cord issues, or whether it's liver compromise. And I think a lot of us are doing this around the edge. From a systemic treatment standpoint, I'm always looking at how dangerous is the cancer at this time, what can I potentially get away with? And if I have a sense that I can get away with axitinib after an evo-ipi because the disease is not threatening, because I know how Cabo performs after a TKI, which is great based on Meteor, or lenvatinib everolimus performs after TKI, those are my two kind of go-to if I'm in a challenging scenario. But if I can get away with axitinib first, I have Cabo. If patients do very well on axitinib for a long time, I think belzutifan in that subset of patients probably performs very well. And you start playing the chess game of how many lines of treatment might I try, and when do I actually have to go for my biggest kind of multi-prong approach. And so that's the strategy that I'm playing, is when can I do cleanup work? How much can I get away with? How much risk am I putting a patient on from not going to my most active drug at that time? And it's just kind of a stepwise approach, working with patients and trying to get as much as you can, because it is clearly a marathon. The chances of cure are likely out the window, and are you going to be on a tolerable therapy where patients can live with as high of quality life for as long as they can?
Yeah. And I'll add the comment, because I've thought a lot about this as well. And I think, David, to your point, and Matt, you're hinting at this too, like in the refractory setting, if we're not achieving cure, if we're adding toxicity, I recently saw in my practice someone who at time of progression was very symptomatic, just third line setting and very symptomatic disease. And I think we do try to assess that. We try to say, okay, what is the pace, or what's the symptom burden, all this. But sometimes it's just really hard, and it's hard to have that conversation to the patient. Do you say to them, will you, again, kind of to your point, is the juice, the squeeze worth the juice? But do you say to them, this might control your cancer for longer, maintain your current quality of life, ability to be active, keep that bony met from coming, and accept a little more fatigue, more anemia, I think it's just a hard question.
It's a hard balance.
I'll be curious to kind of see where some of these, combination treatments end up. And Brett, I was going to ask you as well, we all kind of have our way of thinking about sequencing. Do you think there's a clinical trial design out there that will allow us to
I think it's
test
incredibly
this?
challenging, right? I mean, I think, because at the end of the day, I don't think we have a right answer. I think if you look at that, now we have data for tivozanib, post 2 lines of therapy, so post ipi, post IO TKI, we have Cabo, we have Renev, so we have so many different options. I think some of these trials, combinations will actually be helpful too, because they'll give us some, even on the monotherapy arm of those trials. And I'm curious to see, I share the concerns that it may not pan out, but I do find the HIF-2 has a very unique, it's not a TKI, right? So it has a very unique side effect profile. Now, that can be challenging to manage, but it's different to manage, right? And so I think that's one thing I find exciting about this concept. I think we can maybe even have different HIF-2 inhibitors. So I think there's some really great data on casdatifan, which is another oral HIF-2 inhibitor. Updated results show that 100 milligrams daily seems to be the right dose. And early numbers, but lower PD as best response with that. I think one of the concerns I would have with belzutifan is this, in the phase 2 trial, over 30% of the patients experience progressive disease, right? And that's a pretty high number, especially if you start using that later lines of therapy. So I think it'd be really interesting to see how that drug moves forward. There's trials ongoing combined with cabozantinib and others will be curious.
If you find the belzutifan people, it's amazing. I think in my clinic, 7 or 8 out of 10 patients would say belzutifan is easier.
100%.
And you figure out the anemia, you manage the anemia, you manage make sure they have a pulse oximeter. But if you can hit that 30%, those patients often do well for a good while. And so it's just, can we do a better job of identifying those patients, and are there prognostic features or others that we can say this is the group that we can go down this road.
I would agree. Most patients love HIF-2 inhibitors.
It's a nice break.
They're it's a break. I feel so much better. I can taste again. It's fantastic.
Yeah. And I love this idea because I think that monotherapy of belzutifan does give that treatment break, while everything else we're talking about is essentially de-risking the belzutifan primary progressive response by adding in a TKI. I think though, when we're all very subspecialized, we're all very focused, we kind of try to do a little nuance, how's the scan looking, is this rapidly progressive? But I think too, to our community colleagues who are practicing and seeing like 3 patients with kidney cancer. And so there I wonder if the benefit of having, that high upfront ORR in a refractory setting and then the long-term tail of belzutifan is going to end up winning out. It's somewhat distressing because then we won't get the break from the TKI. But perhaps then in the community also that might be like an easier thing to not have to make all those nuanced decisions and just know, hey, I'm going to have, this combination of treatment options. I have really enjoyed this conversation today. I've grilled each of you, I think, and so it's just truly been a pleasure. I want to thank the audience for joining us, and hope you all have found this insightful roundtable discussion at GU ASCO. Thanks for joining us.